Thank you one and all for being here. I'd like to thank the organizers and everyone in this room. In the want of time, I'm going to go quickly through this presentation, which is a vast topic. My topic today is depression in the elderly. Objectives would be to discuss depressed mood as a problem in the elderly, discuss how to diagnose this problem, and then go through the treatment options for depression. This is something we see every day in the elderly. Healthy aging is something close to all our hearts, and mental illness is something that is commonly ignored, mostly due to lack of awareness. So Mrs. X is a 78-year-old woman who recently lost her husband. Since the death, she's appeared sad-looking, low energy, has trouble falling asleep, has spoken as if she feels like he's in the room and hears his voice calling her name, something we commonly see in our parents and elderly around us. So questions to be asked would be, what is the diagnosis? What should we do next? And what are the treatment options for this woman? There are several diagnoses when we think of mood problems in the elderly. Primarily, there is major depressive disorder. There's dysthymia, which is chronic depression. Bipolar disorder, which is a variant of depression. There is then mood disorder due to a general medical condition, which is very, very common. Substance-induced mood disorder is fairly commonly seen. We also see adjustment disorders with depression and complicated bereavement. Bereavement is what we would think of commonly in this. If it persists, we would then go on to treat this woman. So what is major depressive disorder and how is it different from just blues or feeling low? To make a diagnosis of major depressive disorder in the elderly or in anyone, it has to last for an extended time, which is 2 weeks. A short period of time when we think of it, but a 2-week period of either persistent depressed mood or loss of interest, along with problems with sleep, energy, appetite, worthlessness, concentration problems, and eventually suicidality, feeling hopeless, helpless, and guilty. All of these in a 2-week period in any individual or primarily in our elderly is enough to make a diagnosis of depression, and it needs to be treated. So epidemiology needs to be looked at. Geriatric depression is associated more with females. Women are more prone to depression, though in the geriatric population, men are also very, very highly prone to be depressed. Above 80, the gender differences fade. Other epidemiological factors to look at would be low socioeconomic status, less social support. That is a very, very important thing. If there is not enough social support in their surroundings, it's going to be really difficult, and these people are more prone for depression. Recent adverse life events like we saw in the patient that I portrayed, death and other losses, severe impairment in medical health. Many of us have medical issues, our elderly have many medical issues. We have to look at the psychological, psychiatric sequelae of this and have it adequately treated for them to have good quality of life. Another thing would be to look at is underutilization of psychiatric services. All hospitals have psychiatrists, but not all people are prone to make a referral to a psychiatrist because there is still a big stigma attached with mental health. So we have to make sure that we oversee this and get them the appropriate care that they need. Depression in the elderly contributes to a high suicide rate, unfortunately. Above 65, males have the highest rate of completed suicide. Women have a higher rate of attempting suicide, but certainly men complete suicide more. Is suicide common in the elderly? It's very common, like I said. It's not advancing. I'm sorry, the slide is not advancing? Okay, so definition of depression I've already gone through with you. 2 or more symptoms occurring more than 50% of the time for at least a 2-week period of all of the psychosocial and all of the symptomatology that I just outlined for you. When you suspect depression, what do you do next? You have to look at the medical sequelae. You have to make sure that this patient has had a thorough medical examination and then also sees the psychiatrist. So what do we think of when we're considering depression? We have to look at the elderly. We have to look at the history. Are they on pain medication? Are there high blood pressure medications? These are very, very common. Most of our elderly are on at least 5 to 6 different medications or more. Hormonal effects, cardiac medications, primarily beta blockers, alcohol, anti-cancer agents, talked about recently, Parkinson's disease medications, arthritis medications, very, very common in most of our elderly, and also anti-anxiety drugs. Anti-anxiety drugs should not be used or should be used with caution in the elderly. It is used very frequently by primary care physicians, needs to be looked at and made sure that that is not the cause of depression. Next, we need to go on to, is it a medical condition that is contributing to their depressed mood? Is it hypothyroidism? Very, very common condition. B12 deficiency, vitamin D deficiency, something that we pick up in 95% or more of our elderly population as well as our middle-aged population. Neurological illnesses contribute to about 80% prevalence of depression and other mental illnesses. Cancer and respiratory illnesses. Is it due to dementia would be a very, very important question to be asked. I mean, I'd like to draw your attention to this because depression is commonly ignored in people with dementia. In our elderly with dementia, there is something called pseudodementia. Before we make a diagnosis of dementia, we have to make sure that it is not a depression presenting like a dementia. The intensity varies in 50% of the population, elderly with Alzheimer's as well as other dementias. There are a few rating scales we use. There is a geriatric depression rating scale and then the Cornell scale for moderate to moderately severe depression in dementia. These have to be administered by trained personnel because the patient or our elderly are not expected to give us the history that is necessary to make the diagnosis. Diagnosis of geriatric depression and dementia. Confusion often arises as part of dementia as well as part of depression, and so it can be confusing for the person evaluating. They have communication issues. They can't talk about their mood. So it's very, very difficult to ascertain whether they're depressed or they have dementia or both. Symptoms of other disorders often overlap with depression. Alzheimer's patients have loss of appetite, loss of concentration, they become isolative, again seen across the board in depression. Parkinson's patients lose affect, have slowed speech and movements, and this is also seen very commonly in depression. Frontal lobe injuries post-RTA or road traffic accidents present very commonly with psychiatric sequelae and need to be looked at, especially our elderly post-RTA need to be screened for depression. They have frequent and dysfunctional sad and downcast mood. Now, how do you differentiate a depression in dementia versus just dementia? A person with depression and dementia is going to be more commonly agitated. So rather than just isolating, they'll have more psychomotor agitation. So they're not just psychomotor retarded, or the neurovegetative features are not the same if they have a coexisting depression. Usually it's reported by the caregiver or by the nursing home personnel. We have to look at the patient's past medical and psychiatric history and ascertain whether there is any past history to indicate that they are more at risk of depression. If unsure, certainly go ahead and treat for depression. That is the least likely thing to cause any problems in these patients and in our elderly. Medications are safer and much more effective nowadays. ECT or electroconvulsive therapy is a viable option, safe to do. It's much worse to miss than overtreat for sure. Diagnosis of geriatric depression and dementia. Apathy is a common symptom. It's often mistaken, like I said. How do you tell them apart? How do you treat them? There are treatments that are FDA approved as well as non-FDA approved.
Dr. Meena, you have 2 minutes more.
Thank you. We should go with FDA approved or safe treatment options especially in our elderly. The course is much more chronic. Medications take longer to work. Risk of relapse is much higher after age 65. Rationale for long-term use of antidepressants in this population is there. There is a lot of evidence to support this. Psychotic depression is very common. These patients present with delusions, which are fixed false beliefs, along with the depression, which makes it very difficult for them as well as for the caregivers. They have highly systematized delusions which need to be treated and are treatable. What medications do we use? There are various antidepressants. SSRIs are the most common. SNRIs are used as second-line antidepressants. Mostly we start low and we go slow, and we make sure that they have other options of support like psychotherapy. Psychotherapy is very important in these patients. I'm going to skip ahead for want of time. Psychotherapy, there are several forms of psychotherapy. Cognitive behavioral and supportive psychotherapy is what we use primarily. Psychodynamic, used a little less. Problem solving and problem focused psychotherapy is usually very useful in these patients. They are more responsive to the antidepressants if psychotherapy is done along with the medication management. ECT works rapidly, it works well. It's not commonly known, but ECT is a safe option in our elderly. So conclusion, geriatric depression is a common problem. It's commonly unrecognized due to lack of awareness amongst caregivers. I would hope that caregivers would be more aware and would get their elderly into treatment. Treatment options include medications, ECT, and psychotherapy. Medications are certainly a safe option. Lack of treatment increases suicide risk considerably. Thank you.
Thank you, Dr. Meena. You really got us to the insight of the details of how you can take up the treatment depending upon whether depression was due to dementia and the less social supports which add up to the value of what the human being was going through during the phase of their elderly, the loss of a partner and all these adding up to the complex situations of continuing with such a phase. And it's really needed that we give back life to the individual by your care and love and affection. Thank you.
Thank you,
And
Dr.
I would like to
Rajeshwari.
wind up in just a minute. I'll just announce and I'll just go ahead with that. This is Avinash Bhai Patel, a student in the Department of Humanities and Social Sciences, IIT Roorkee. Rising fear of crime among the elderly is the topic, and I think it's the need of the hour that we are going to hear him talk about this. Thank you, and thank you, Dr. Meena.
Thank you, Dr. Rajeshwari.
Let's give Dr. Meena a big round of applause once again. Thank you.